Hello and good morning, everyone. I present to you the TOG summary for July 2023. This will be particularly helpful for the exam next week. I wish you all the best and I hope that you'll find this TOG summary really useful. So the three TOG articles that we're going to talk about in this presentation are as follows. So TB in pregnancy. Number 2 is quantification of blood loss in obstetric hemorrhage, implications on intervention and transfusion. Number 3 is gastrointestinal congenital anomalies requiring surgery, diagnosis, counseling and management. So the first TOG article that we're going to talk about is tuberculosis or TB in pregnancy. So TB is the leading infectious cause of mortality. There is worldwide more than 1 million deaths. Hence it becomes an important topic to read and educate on. There's 8 countries which include India, China, Indonesia, Philippines, Pakistan, Nigeria, Bangladesh and South Africa that have 2/3 of the cases of TB. For women who are born in the UK, but to parents from the ethnic minorities, they can present late with non-specific symptoms and especially with symptoms of extrapulmonary TB, which increases the likelihood of a delayed diagnosis. The risk of new migrant women developing active TB is greatest in the first 5 years after coming to the UK. The Mycobacterium tuberculosis is the bacteria that is the cause for TB. It's a non-spore forming organism. It's aerobic and non-motile bacillus. This is just a bit about the bacteria. TB is normally airborne infection, which means it's spread through droplets either by the infected person coughing or sneezing and another person inhaling that. However, this is interesting and I did not know this actually. Infection can also occur through ingestion of unpasteurized milk or direct implantation through abrasion in skin or conjunctiva. Important not to touch your eyes when you are in public. So, pulmonary disease is the most common form of TB. It involves the granulomatous reaction following pulmonary infection with involvement of the regional lymph nodes from to form a GON focus. 20% of active TB can present as extrapulmonary TB. Most common extrapulmonary disease in pregnancy in the UK is seen in the cervical lymph nodes. That's about 31%. The other sites that TB may be seen in is the central nervous system, spinal cord, the abdomen and the pericardium. So the outcomes for a primary infection with TB include latent TB infection, where the patient can be asymptomatic, non-infectious. It can be primary TB disease within 2 years of infection or secondary TB. The diagnosis may be delayed in pregnancy owing to symptoms that overlap normal pregnancy physiological symptoms. So except fever, things like weight loss, night sweats, chills, loss of appetite, tiredness and weakness. The WHO, so the World Health Organization, suggests 4 symptoms for screening, which include fever, night sweats, cough, and weight loss. So investigations for TB can be classified into screening tests, which is the TB skin test, interferon gamma release assay, confirmatory tests like the microscopy, culture, and sensitivity, and additional tests like imaging can be done. The lone stain Jensen medium is traditionally what's used for culture and sensitivity of the Mycobacterium TB. Culture can take up to 4 to 8 weeks, and drug sensitivity could take a further 6 to 8 weeks. Chest X-ray is good at screening as a screening tool and should be used in pregnancy when clinically indicated. Ultrasound can be safely used for obtaining tissue, for aspiration samples, for histology and microbiological investigations. MRI should also be considered before CT in the investigation for pulmonary or extrapulmonary TB in pregnant women. The baseline risk of death following a childhood cancer is 1 in 2,000. This risk is doubled to 2 in 2,000 after exposure to 5 rads of ionizing radiation in a pelvic CT during pregnancy. Quite important figure for you to know, as this will help you even counsel patients when you are discussing CT scans for whatever reason of the pelvic area in a pregnant woman. Right, so specific to the pregnancy, the immunological changes during pregnancy increase the susceptibility to TB in the first place. They increase risk of primary TB or reactivation of TB as well. Pregnancy can make the diagnosis of TB more challenging, as we said that some of the symptoms can overlap. In the postpartum period, there's an increased risk of reactivation of disease, and susceptibility of women to TB during this period is higher than in non-pregnant women with similar demographics. This is quite important if you're seeing a patient with TB in pregnancy to be aware of these special situations, especially also in the postpartum period. The cause and the prognosis of TB in pregnancy is determined by the severity of the disease, the susceptibility to infection as well, and the susceptibility to the medication and the organ involvement. Also, if the patient, for whatever reason, is on immunosuppressants, the susceptibility then increases as well. The maternal and neonatal outcomes depend on the stage of the disease process, the gestational age, diagnosis, treatment received, presence of extrapulmonary disease, whether there's co-infection with HIV, and whether there's presence of other comorbidities like diabetes and other autoimmune disorders. Pregnant women with extrapulmonary TB have increased incidence of anemia, oligohydramnios, hypertension in pregnancy, gestational diabetes, preterm premature rupture of membranes, PROM, cholestasis in pregnancy, small for gestation age, low APGAR scores, and significant differences in neonatal respiratory distress syndrome in pregnant women with extrapulmonary TB. Genital TB accounts for about 50% of cases. Perinatal TB has a high mortality rate for both the treated and the non-treated neonate at 22% and 38% respectively. We'll talk more about perinatal TB in a bit. Right, so treatment of TB, which does not involve the central nervous system, includes isoniazid, rifampicin, pyrazinamide, and ethambutol for the 2 months called the initial phase, followed by isoniazid and rifampicin for the following 4 months, which is called the continuation phase. The duration of treatment is 6 months. Now, where there is central nervous system involvement, the recommended treatment is for 12 months, and it involves isoniazid, rifampicin, pyrazinamide, and ethambutol for 2 months, then isoniazid and rifampicin for 10 months. Pyridoxine 10 milligrams per day is given along with isoniazid during both the initiation and continuation phase as there's increased requirement during pregnancy, and this mitigates some of the risk of neurotoxicity to the mother and the neonate. For the latent TB in pregnant women with latent TB infection, they should be considered for prophylaxis if they are HIV positive at high risk of having acquired TB recently. So if there is the entrance from a high prevalent country, there is close contact with person of pulmonary or laryngeal TB, or after investigation which proves to be positive. Delaying treatment in second trimester is not recommended, and commencing treatment in first trimester has been shown to reduce the risk of neonatal complications and almost prevent miscarriage, preterm labor, and perinatal mortality and morbidity. The treatment for latent TB is isoniazid for 6 months, or a combination of both isoniazid and rifampicin for 3 months. Pyridoxine with isoniazid is initiated. The 2 drugs are safe during pregnancy for both the mother and the unborn child. Hepatotoxicity associated with isoniazid should be expected in the 3rd trimester or early postpartum period. However, these risks should be balanced by the risk of developing active tuberculosis infection. Right, so management of TB involves a multidisciplinary team. This team involves a caseworker, health visitor, obstetrician with special interest in maternal medicine, infectious disease specialist, medical microbiologist, TB lead physician, nurse, pharmacist, respiratory physician, neonatologist, psychologist, public health specialist, GP, peer support group, housing officer, and voluntary groups. Breastfeeding is not recommended if there is breast TB or multi-drug or extended drug-resistant TB, or there's co-infection with HIV. So perinatal TB is acquired congenitally and postnatally. So TB acquired by the fetus in utero, either antenatally or intrapartum, is considered as congenital TB. If it's acquired by the fetus in utero, either through the placenta or the amniotic fluid or the umbilical vein, when the mother has active TB. Neonatal TB is more likely to occur in the postnatal period and is usually acquired in the immediate postpartum period when the neonate is in close contact with an open, active, sputum-positive case of TB. Primary focus in the neonate is the liver and the periportal lymph nodes, compared with adults in whom it's most commonly observed in the lungs. Miliary pattern commonest finding on the chest x-ray in the neonates. Perinatal TB is usually diagnosed with placental histology and culture, chest x-ray, and use of either culture and molecular diagnostic of the cerebrospinal fluid, or gastric or tracheal aspirates can be of help in arriving at a diagnosis. So a little bit about the BCG vaccination. So the vaccination is a live attenuated vaccine from Mycobacterium bovis. It should be avoided in pregnancy. It's contraindicated in infants who are exposed to immunosuppressive treatment in utero, or in breastfeeding children with an active TB case suspected or confirmed in their household. For infant born to a HIV positive mother, if the infant is HIV negative, then at 12 to 14 weeks, the child and if the child is exclusively exclusively formula fed, then they should be given the vaccination. The treatment of TB can be quite challenging, as we've discussed. The treatment involves quite a prolonged period of treatment. However, the antibiotics have also got lots of side effects. So, for example, the isoniazid causes liver injury, peripheral neuropathy, and neuritis, seizures, severe cutaneous adverse reactions, psychosis, lupus-like syndrome, vasculitis, and pancreatitis. Rifampicin is known to cause side effects like nausea, vomiting, liver injury, acute kidney injury, severe cutaneous adverse reactions, along with discoloration of saliva, urine, and sweat, anemia, thrombocytopenia, pyrexia, and adrenal insufficiency. Pyrazinamide is the side effects include arthralgia, dysuria, gout, liver injury, photosensitivity, sideroblastic anemia, and splenomegaly. Ethambutol side effects include gout, neuritis, kidney injury, alveolitis, flatulence, photosensitive lichenoid eruption, and severe cutaneous adverse reactions. You can see how the compliance of patients may be affected due to these quite severe side effects. Okay, this helps us now to move on to the next TOG article, which is the quantification of blood loss in obstetric hemorrhage, implications on intervention and transfusion. Right, so BPH affects 2% of women worldwide. It's a leading cause of maternal mortality in low-income countries. It accounts for 27% of all maternal deaths. That's a big number. 27% is nearly 30%, which is a third of all maternal deaths, is because of the blood loss. In UK, hemorrhage is fourth commonest cause of direct maternal death. This is quite an important number to know for your exams. BPH can cause significant morbidity, including anemia, coagulopathy, and renal failure, pulmonary dysfunction, visceral injury, hysterectomy, and cardiac arrest. There can also be a psychological impact leading to poor postnatal outcomes such as post-traumatic stress disorder, postnatal depression, and negative impact on bonding with baby and breastfeeding. Future fertility can also be affected if the need was for a hysterectomy, for example, or there's something called Sheehan syndrome, which can develop because of hypoperfusion of the pituitary gland associated with the hypotension from severe BPH. In 2020, 24% of all deliveries in England were complicated by a BPH of more than 500 mils. Complications associated with transfusion include infection, circulatory overload, acute lung injury, anaphylaxis, transfusion reactions. The risk of dying from blood transfusion is still is low in the UK, and it's 1 in 53,193. Okay, so because of the blood loss, there can be coagulopathies associated with BPH. This could be dilutional because of the blood transfused, because of the blood products and the blood that's being transfused. It could be local consumption of the clotting products. It could be disseminated consumption and fibrinolysis. Okay, so the normal range of fibrinogen in pregnancy is 2 to 4 grams per litre, with higher levels in the third trimester. During continued BPH, fibrinogen levels of less than 2 are highly predictive of progression to severe PPH. Therefore, the aim should always be to maintain levels above 2 grams a litre. Normal physiological changes in pregnancy can lead to an increase in plasma and blood volume of 40 to 50%. This increase helps maintain circulating blood volume, blood pressure, and uteroplacental perfusion. Cardiac output also increases by up to 45% in pregnancy because of the increase in metabolic requirements, and a further increase is seen in second stage of labor. The shock index is calculated by dividing the heart rate by the systolic blood pressure. It is a more useful tool for assessing morbidity and mortality and the risk of developing shock than vital signs alone. So there are tests that you can do at the time in order to find out more about the coagulation profile. There's two types of these tests. One is called the TOG, and the other one is ROTEM. Different hospitals that you may be working at may already be using these tests. Basically, they provide a rapid assessment of the coagulation using citrated whole blood by measuring clotting factors in the extrinsic pathway and fibrin in the formation of clots. So they work by allowing a formation and breakdown of a clot. This results in reduction in blood loss and blood transfusion when TOG and ROTEM are used in conjunction with agreed algorithm to help guide the management of hypofibrinogenemia and thrombocytopenia in a PPH. So what they're trying to say is the trust your local hospital should have guidelines as to how to interpret the results of these two tests, and this can significantly reduce blood loss and also blood transfusion products. So this table compares how you can estimate blood loss when there is a PPH. For example, there can be visual estimation of the blood loss. This does not require any equipment. Estimation can be improved with regular training. It's free. It can be inaccurate, however, which can lead to poor management of postpartum hemorrhage. There can be variance of estimation across different practitioners, which can also lead to disputes and disagreements, which I'm sure you all have come across in your very fulfilling careers. Now, another way of measuring is called gravimetric, which means blood loss is determined by assessing the weight difference before and after the use of swabs, drapes, with every gram of weight equivalent to 1 ml of blood loss. It's easy to implement. It's closer volumes to blood loss than visual estimation. It can be done in real time with quick results. However, equipment is required, it's time consuming, contamination risk leading to higher volume estimates. So there could be contamination from, for example, amniotic fluid. There could be other fluid spillage that could again account for this, and this would be added into your blood loss as well. There can be risk of underestimation in fluids that are not collected. So if there isn't any blood physically on the swabs or the drapes that are being measured, then the blood loss might be missed. There is volumetric measurement, so measurement of blood loss volume using under buttock drapes and canisters, which may or may not be calibrated. So it's easy to implement, closer volumes to blood loss than visual estimation, can be done in real time with quick results. It requires equipment. There can be contamination risk leading to higher volume estimates. There's risk of underestimation in fluids not collected. There's another way of measuring, which is photometric, which means total blood loss is collected, then hemoglobin is extracted and stabilized using a spectrophotometer, the hemoglobin mass is calculated. Its accurate volume of blood loss, plus or minus 10%. The used as gold standard for hemoglobin calculation. Requires equipment, is time consuming, cannot be done in real time, requires pre-op hemoglobin as well, and the cost of the equipment. Another way is colorimetric, which basically means photographic and geometric information from relevant areas is analyzed by a smartphone application. Hemoglobin mass is calculated and compared to the admission hemoglobin. Correlates well with the gold standard, however, requires equipment, is time consuming, the cost of it, and requires pre-op hemoglobin levels as well. I really love this slide. I feel like this is one slide that you really need to take away from this TOG summary. Look at how beautifully everything is summarized in this slide for you. So it talks about clotting factors that are increased during the pregnancy, that are decreased during the pregnancy, where there's no overall change in them as well, and it talks about procoagulation factors, anticoagulation factors, and splits them into different boxes. You have to give it at least a few minutes to absorb the information from the slide, because it can result in lots of very easy EMQ and SBA questions for your exam. So I'll let you spend a bit of time on the slide. Right, so I said that the point of testing kits measure clotting factors in the extrinsic pathway. So I think this is what I was talking about. For clotting to be successful, there is an extrinsic pathway, intrinsic pathway, and then there is a common pathway. So this is what I was talking about. I think it's quite helpful to know how these pathways integrate with one another, and also what factors may be involved, as again this can be quite easy marks for an SB or EMQ question. Okay, we now move on to the last TOG article of this presentation, which is gastrointestinal congenital anomalies requiring surgery, diagnosis, counseling, and management. Right, so WHO, which is the World Health Organization, estimates that 6% of babies are born with a congenital anomaly worldwide. Gastrointestinal congenital anomalies represent about 10% of this. So quite a significant proportion. Anterior abdominal wall defects include gastroschisis and omphalocele, are the commonest GI anomalies. The prevalence is approximately 3 to 6 in 10,000. These conditions require surgery as a key component of neonatal management. The early pregnancy scan between 11 and 13 plus 6 weeks predominantly assesses pregnancy viability, number of fetuses, chorionicity, multiple pregnancy, and provides opportunity for screening of trisomy 13, 18, and 21. Ultrasound detection rates for anterior abdominal wall defects are greater than 90% at this point in time. The Fetal Anomaly Screening Program, shortened to FASP, recommends an anatomical scan at between 18 and 21 weeks. Gastroschisis and omphalocele are two of the FASP designated conditions screened for targeted detection rates of 98% and 80% respectively. So it's gastroschisis, the detection rate should be 98%, and omphalocele should be 80%. So quite high numbers there. Right, so what is examphilus, which is also known as omphalocele? It's a central ventral abdominal wall defect through the umbilicus with umbilical cord insertion at its apex. Herniated contents include small bowel, liver, with a peritoneal covering. Approximately 50% of omphaloceles will contain liver. Definitions of giant omphalocele vary, but are usually recognized as being greater than 5 centimeters in diameter or having more than 50% of the liver in the sac. Narrowing of the fetal thorax leading to pulmonary hyperplasia and respiratory difficulties are more likely in this group. Physiological herniation of the fetal gut occurs during the 6th to the 10th week of gestation of embryonic development. Failure of the bowel loops to return to abdominal cavity are believed to be the embryological basis of an omphalocele. Gastroschisis is a para-umbilical defect in the anterior abdominal wall. The umbilical cord is normally inserted with defect commonly to the right. Small bowel is often herniated with no peritoneal covering. Quite an important difference. So in omphalocele there is peritoneal covering. Gastroschisis is no peritoneal covering. Lack of peritoneal covering to protect viscera and risk of compression at the site of defect can lead to peritoneal complications, including volvulus, atresia, ischemia, necrosis, defined as complex gastroschisis. Incidence is increasing. Risk factors include younger maternal age, less than 20 years, maternal smoking, maternal cannabis use, and low BMI. Up to 25% of cases may be complicated by oligohydramnios, secondary to decreased umbilical blood flow and fetal growth restriction. Most gastroschisis cases are associated with elevated alpha-fetoprotein, which may be identified on the quadruple screening test. Fetuses with gastroschisis are increased risk of stillbirth, up to 5% under 35 weeks. However, fetal growth restriction, oligohydramnios, hypovolemia secondary to fluid shift across herniated bowel, umbilical cord compression secondary to intestinal dilatation, volvulus, or vascular compromise all also account for the increased risk of complications. Overall, neonatal survival is over 90%, so it's quite good. Right, an abdo X-ray performed 2 hours after birth to allow passage of air through the bowel. If the double bubble sign or duodenal atresia is not seen but is clinically suspected, then air could be injected through an NG tube to help distend the stomach and the first part of the duodenum to aid the diagnosis. Duodenal atresia repair can be performed via open or laparoscopic surgery. MDT management is important in these cases as well as counseling the patient for options of treatment and management, which should also include termination of pregnancy when this has been picked up antenatally. So this itself has lots of implications, as you can see, not only just physical but also psychological for both the mother and the families involved. Hence, discussions should take place in a multidisciplinary team meeting with the parents given a chance to meet the surgeons who will be operating on the baby after birth, before the baby is born, so that the parents are informed of what is to be expected. Well, that summarizes the 3 articles in the July 2023 TOG. I hope you found these really useful. If you do need to contact me, then please don't hesitate. My email address is reviseyourbasics99@gmail.com. If you want to leave me any feedback, that'd be great. If there's any videos that you'd like me to do, then please do. You can comment under the video, or you could email me. I'm also going to summarize the rest of the TOG articles for the July 2023 TOG. I'm also hoping to get the videos out before your exam next week. I'm also going to post some questions for these two TOG issues as well, which is the July and the October one, so that you can get lots of revision and practice before your exam. Good luck revising. Just if you haven't seen my post already, but I've done a booklet of for MRCOG part 2 notes, revision notes from the guidelines. It's a quite comprehensive, summarized PDF booklet of important tables and points that you need to know for your MRCOG exam. I have provided the link in the post that I did for the notes, but I'll also provide it under this video. If you are interested in buying a copy, then do let me know. Good luck revising.